My name is Iris Zink. I am a rheumatology nurse practitioner in East Lansing, Michigan. I have been in rheumatology for the last 26 years. I am passionate about taking care of my patients. We have two locations in East Lansing, and we are a rheumatology nurse practitioner clinic. Today, we're going to talk about intimacy and chronic disease and why sexual health is relevant in rheumatology. So, sexual problems are frequent in every single autoimmune disease. Every single form of arthritis has sexual health impact. So, why is this relevant? It is very relevant to rheumatology. The problem is that it is not a routine diagnostic process for any office to ask about sexual health, nor to have any kind of plan created around sexual health problems. Sexual health is not yet a routine part of any diagnostic workup or therapeutic planning. Intimacy, what does that mean? Intimacy is not purely physical. It's the act of connecting with someone on such a deep level that you feel like you can see down into their soul. Many of our patients cannot have penetrative sex. So when I talk about sexual health, I'm not talking about penetrative sex. Many of our patients, that's just not possible because of pain. So when I talk about sexual health, I'm talking about intimacy, maintaining normalcy. Sexual health is a normal physiological function, just like being able to cough, just being able to have a bowel movement, just being able to stop having the hiccups. Having an orgasm is a normal physiological process that we need to have a conversation with our patients about. How is that going? How is your sexual life? How is your autoimmune disease impacting your physical and sexual health and your relationship status? So when I use the words like intimacy and sex, sometimes I use them interchangeably, but know that I'm talking about maintaining a relationship with a partner. I'm not talking about penetrative sex. Why is sexual health relevant in rheumatology? Two-thirds of patients with hip and back osteoarthritis experience sexual health problems. 62% of patients with rheumatoid arthritis reported difficulties with sexual performance. 50% of patients with ankylosing spondylitis report issues with decreased desire, satisfaction, and frequency of sex. And 71% of patients stated that fibromyalgia put a strain on the relationship. We know how many fibromyalgia patients have issues with intimacy, with issues of being touched, with issues of being chronic pain. And we know that the divorce rate is double in the patients with fibromyalgia. It is our obligation to treat patients holistically and bring up sexual health. We've all seen this picture of ankylosing spondylitis. That's how I became so passionate about talking to patients about sexual health. I had a 54-year-old patient who was a teacher who told me that she could not open her legs wide enough to have intimacy with her husband any longer. Her sacroiliac joints were fused. It was the old days before we had biologic medications that we could use readily for these patients. And she was unable to have penetrative intercourse with her husband anymore because of her ankylosing spondylitis. Back then, she asked me what to do, and I just looked at her. I got several articles from the library. I told her I was going to get back with her. I called her back 2 weeks later. We set her up with an osteopathic doctor in town. We set her up for some osteopathic manipulative medicine, some physical therapy. And she states that that really did make a difference in her ability to get some flexibility so that she can have what she would consider a normal process or a normal intimate relationship with her partner. But I didn't know what the answer was. The most important thing was that I didn't give up, that I didn't say I didn't know, that I sought out these answers and that we need to communicate with our patients. So not just ankylosing spondylitis. What about Sjogren's? We know about dry eyes. We know about dry mouth. We know about dry vagina. But it's dry vagina to the point where they can actually have fissures. They can have bleeding. They can have extreme pain with penetrative intercourse. They can get infections because of the fissures that they experience. And not to mention the fact that they have neuropathy. They cannot feel their vulva or their clitoris. Men with Sjogren's tend to have less ejaculate. They have more difficulties with erectile dysfunction. So are we addressing that need with our patient when we don't address their sexual health at all? There are lots of things that we can do that'll make a huge difference in these patients. We can recommend hyaluronic acid inserts or hyaluronic acid gel that they can put in their vagina to help plump the tissue, to help make penetrative intercourse possible, or at least make it so it's not painful. There are many options now, not just estrogen cream, and the gynecologists are not also addressing this with our patients. We need to be informed about the options for our patients. If the patients cannot feel their fingers and toes because they have such extreme Raynaud's, they probably can't feel their clitoris or their vaginal area. So let's go over the 10 myths of sexual health. Sex is intercourse. That is not true. You can have intimacy without penetrative intercourse. The goal of sex is orgasm. A lot of our patients are just not able to achieve orgasm anymore. So the goal cannot be orgasm. You can have intimacy without the goal of achieving orgasm. General health does not affect my sexual health. Well, we know that that's a myth because every single disease, even sleep apnea, blindness, multiple sclerosis, everything affects your sexual health. What about the use of sexual aids? Is that not sexy? Well, if you can't feel your clitoris and you can't feel your vaginal area, you may need lots of extra stimulation. The same thing is true if you have osteoarthritis and it's impacting your exiting L4-5 nerve roots. You may have lost sensation. That may be causing erectile dysfunction. And so you may need a lot more stimulation in order to get to the point of erection or orgasm. Good sex just happens. That's another myth. You need to plan for it. You have to have privacy. You have to have a date. You have to be physically ready. Again, if you have a woman with vaginal dryness, she has to be prepared for that penetration. You have to have enough lubricant. She has to be using hyaluronic acid inserts regularly so that her vaginal health is good. She may need pelvic floor physical therapy. So you have to have a time frame when everyone is prepared for intimacy. Disabled people are not sexual. Disabled people are sexual. We are sexual from the time we are born until the time we are put into the grave. That is our sexual life. We are always sexual beings. So there's not a cute little man sitting in a wheelchair who's just being cute. He's being sexual. We're all sexual beings and we all have sexual desires and sexual needs. That's another thing I wanted to mention is that a lot of women, after they're diagnosed with autoimmune disease, they say, I just don't feel like I am in the mood anymore. There's something really wrong with me. I don't have sexual desire anymore. Well, when you're thinking about chronic pain and you're thinking about how you're going to get your work done and you're thinking about your kids and their problems and getting the laundry done and doing the dishes and just cooking a healthy meal, your own physical pleasure sometimes takes last priority. And you can help your female partner, if you have a female partner, get in the mood by, saying it's okay to take a time out. It's okay to feel pleasure. What kind of activities can I do around the house to help get off of your plate so that we can have intimate time together? But that requires planning and communication. There comes a time when sex is not important. I hope that's not true, but because sex is normal, it's a normal act. And when people are diagnosed with autoimmune disease, they feel like they've lost periods of normalcy. So we have to help the patients maintain that normalcy in their life. My health and physical changes no longer make me attractive. Again, that's a lot of psychological baggage that these patients are carrying around. When I'm diagnosed with lupus and I have this malar rash or I have psoriasis on my genitals, am I just not physically sexually attractive anymore? We need to help them get counseling and to realize that they are still sexually attractive because that comes from within. It is not having all kinds of plastic surgery and fake boobs that makes us sexual people. It comes from within. Sexiness comes from within our soul and being confident and being pain-free maybe, or being comfortable in our own skin. That's where sexuality comes from. I am who I am because of my parts. We know that a lot of ladies who have mastectomies, hysterectomies, men who have prostatectomies, they feel like they've lost their sexual self. And can we help them regain that? And have they been to counseling and have they discussed these issues with other people? And lastly, there is nothing more I could possibly learn about sex. That is so not true. We are all lifelong learners, and we can help our patients learn about their own anatomy. A lot of people don't realize that there are more than one places for stimulation. I mean, I had a classic patient that was a quadriplegic that always wanted his home health care nurse to rub him from the nipples up. That was his sexual stimulation area. So we need to really be aware of where the stimulation is coming from and that we can learn how to make our intimacy change as we age and as we evolve with our own health problems. So, the most important thing we need to do with our patients is communicate. I have done this lecture across the United States to healthcare providers and to patients over and over again for the last 15 years. And the most important thing is that you try, that you care. You care enough to communicate with your patient. And if you don't feel comfortable communicating with your patient, find a nurse in your office who does feel like they can communicate with their patient. Find a resource, find a pelvic floor physical therapist that's very comfortable talking to the patient. Find a sexual therapist that the patient can go to. It's about helping the patient achieve normalcy. And lastly, because so many people asked me, I wrote a book called Sex Interrupted. It's available on Amazon. I co-authored it with a lady who's working at the Lupus Foundation just for patients and also for healthcare providers about feeling comfortable talking about sex and chronic disease. There's a lot of resources out there, but this is just one of the resources that your patients can reach for. I have lots of references for this talk. If you have questions, please reach out to me. I would love to discuss this topic more. Please call me, email me. Jack Cush, Dr. Jack Cush will have my contact information, and please tune in to RheumNow for more information. Thank you so much for sharing this time with me, and I really appreciate you. Go talk to your patients about their sexual health.